So we are open for questions.
Dr. Candy, fantastic lecture. Thank you. Do you routinely inject with PRP then when you do your allograft plugs, your autograft plugs, or with microfracture?
I do both. And again, because we need to increase the biology in the area. The big problem here is what's PRP, and there are so many different companies out there producing it, or producing systems that tell us it produces PRP. And they're all different concentrations, and they all have different varying amounts or different concentrations of growth factors in them. And that makes meaningful analysis and science very difficult. So I think, the ICRS last year, the decision was made that no publication would be, or no manuscript would be accepted for publication unless you try to quantify what you were putting into these defects. So PRP, for definition, is just concentrated platelets above base level. But I think PRP works differently in cartilage than it does in tendon, than it does in bone, than it does in muscle. So we may have to come up with different systems or a way of filtering out the varying growth factors for each system. So if you start reading the literature about PRP, just be careful what you're using. I'm not sure, do you guys have a system here?
Here we have
Biomed. And Biomed is a terrific system, but if you look at the profile of Biomed by comparison to some of the others, it has a slightly higher white count. And what's that doing to the cartilage, and what's that doing to tendon? And it's slightly different. So just be careful how you use it.
Sort of follow-on question. Is that a single-time injection, like immediately post-op?
It is.
Bring it back in a week and give them another injection?
No, and again, this is, we give PRP at the time of the procedure in a dry scope. And we were always very worried, is it going anywhere? And we're trying to use fibrin glue to keep it in the right place. And one of my residents just said, half of this stuff's getting squirted out anyway, Doc. Why, what are we worried about? And I took that on board, and he's right, because it's not a local effect. And again, I didn't stress it enough. Think of these lesions not just as lesions. This is a system. The ankle is a system. It's a joint. And PRP doesn't act just locally. It also acts on the synovium and all around to turn on the other cells there. And I think that's why when we do inject it into the joint and it goes everywhere, I think that's probably why it has a positive effect. But again, getting back to your question, I don't want to hog the microphone here, but we don't know. It's like having a Martha Stewart's cake. We don't know the ingredients. We sort of have ideas, but we don't truly know the quantity. So there may be negative feedback loops. I know from looking at MRI, sometimes I see this synovial hypertrophy in the front of the joint. And I'm sure that's caused by PRP. It doesn't seem to do them any harm. But I think we have to look at it a little bit more closely.
One question also for the other surgeons. PRP for cartilage, I think most.
Microphone, sorry.
PRP for cartilage damage. Maximally, there's maybe a level 5 evidence. So why are you all using it? And are you planning to do some good studies?
Well, I hope, again, that we showed that there's lots of basic science evidence. I think it's compelling. I think that the studies that we are doing at the moment we're working level 1 studies. There are at least 14 or 15 level 3 and 4 studies out there. The big problem, we sort of put this idea that the only thing we believe is level 1 studies. Level 1 studies in the United States are almost impossible because the amount of funding, they're trying to bring people back and so forth. So we've set a bar very, very high for ourselves. I think I would believe level 2 or level 3 studies. I don't believe anecdotal stuff, but I think what we presented here is far from anecdotal.
Level 1? Yeah, okay, you go on.
What do you mean? Is it based on animal studies? Because that's what you showed in your slides.
No, it's not just based on animal studies. It's also based on our own studies where we have published in Cartilage with MRI T2 mapping, where it's not just based on outcomes. We've looked critically at the difference between those patients who've been treated with PRP, BMAC, and with BMAC alone and without. And that's in the AOT group, and we are publishing that in the microfracture group also. And I think you have to look at Giannini's group. He's published this maybe 3 or 4 years ago, where he showed there was a significant difference in those patients who were treated with PRP BMAC as compared to those who were not. Again, a level 4 study, but nonetheless worthy of attention. Do you use PRP? I'd probably not.
So that was the question to the other surgeons.
No, for the moment, surgically, we don't use it.
Hold it closer, Peter. Yes, closer.
No specific comment for that. We don't use it as a standard protocol here in surgery.
Regarding level 1 studies, it has been shown that it's not easy to perform in the US due to several reasons. And they are historically much easier to perform, for instance, in Europe and Northern Europe, Scandinavia, etc. So maybe this is a venue that we could have a multi-center large studies on level 1 studies. And this might be something that we would need to look into in very close future. Comments? Question? Use microphone, please. Yeah, you have 2 microphones coming your way.
Thank you. For the posterior tibio-talofibular ligament, you described inflection, dorsiflexion, there is a stretch or relax. But in case of sprained ankle and neutral position, this ligament can be affected or not?
Yeah. Maybe I don't explain very well. Is the change of the position of the ligament is the posterior intermalleolar ligament. This is the ligament change in the position. Maybe the posterior talofibular ligament don't change in relation to the kind of tension. When you have plantar flexion, your ligament is relaxed, the posterior intermalleolar ligament. In dorsal flexion is in tension. In neutral position, maybe only the role is a reinforcement of the capsule joint. When you have ankle sprain, maybe the reason of the posterior ankle impingement is some lesion of the ligaments around the capsule, and this intermalleolar ligament is more thick and with osteogonum, with some other things can impinge in this case. But I don't know. I respond your question. I answer your question.
That mean affected. That mean it can be stretched. Can be there is a lesion of this ligament or no?
Yeah, of course. Yeah. Maybe this ligament is in the hyperdorsiflexion. Is lesion. I work with Jorge Batista, is a surgeon from Buenos Aires. Is the team of Boca Juniors, and he has some patients with a hyperdorsiflexion, with a lesion of this ligament, and also with a small osteochondral bone fragment for I don't know in English, arrancamiento, bone fracture from the tension of this ligament in the hyperdorsiflexion.
You showed us that there are 2 parts of the ligament, one more inferior and one little bit more posterior. Does it have any implication on the injury mechanism or?
Of the posterior ankle impingement?
Yeah.
But this in relation to the syndesmotic ligaments?
Yeah.
It's not the anterior the syndesmotic ligaments is many studies, but it's not in relation to the posterior. I think the posterior ligaments, the deep component, has a big important role in the stability of the ankle joint, but it's not many papers in relation to this. I think it's one of the next studies to make.
There's a question, gentleman
yes.
here.
I just want to make a comment that, you know, it's always great to come to these meetings because you learn so much, and just looking from at Pau's dissection, one of the problems I think with the rostrum, and which is the standard lateral ligament reconstruction that we do, is that we've been told this is the greatest operation, and patients typically do very well, and there's a Gould modification to it. But oftentimes you have a patient who comes in with a very tight or very arthritic subtalar joint several years after you do a rostrum. And we always blame the Goulds of pulling over that inferior retinaculum too tightly might do it. But I think that one of the things that I noticed from your slide was that the talocalcaneal ligament is very difficult to differentiate from the inferior band of the ATFL. And I think when we're doing our plication with the ATFL in a standard rostrum, over-tightening that may indeed over-tighten the posterior facet, and that's why they get that arthrosis. So I have to be a little bit more careful of that. And I noticed that you work also in Pittsburgh, and we all know and love Freddie Foo's double bundle. The fact that the ATFL now has 2 bundles, is this something, do you think, anatomically we should be?
May I just make one comment on this? First of all, we talk about Broström. The correct spelling is Broström. He was a Swede, and he published in 1966, and he didn't make a reconstruction. He just sutured the ligaments together. In his original publication, he said that he was able to dissect the anterior talofibular and the calcaneofibular ligaments. He just divided them and put sutures in them, and he didn't do any reconstruction at all. And I think that he has got his name. He just recently died. He has got his name on reconstructions that other people really have done. Okay, doesn't really matter. We have one question here.
Actually, thank you for your really interesting lectures and speech. I have just a question regarding the correlation between the pain and the hydrostatic pressure as management, pain management. Do you have any correlation between the cyst and subchondral cyst and the pain when I see the joint as an ankle joint, the pain as satisfaction of the patient or the player, if he has pain or he has no pain. And at the same time, I see that the old joint, the pain become more difficult just to catch it. So whether you believe that all the pain comes in ankle with the sprain or any sort of injury in the ankle due to hydrostatic pressure, or there are other factors as well related to the pain. Thank you.
I'll kick off because I have it, and I think this is a terrific question, because when you look at an MRI or an X-ray and a patient has pain and you see an OCL, your initial reaction is that is the pain generator. And I think what you have to do is, and that's the beauty of an MRI, you can see whether there truly is a reaction around this or inflammatory response around the cyst. To the best of my knowledge, cyst size has no correlation with pain. But the presence of a cyst does have a direct correlation with pain. And so if you have a cyst and you inject the joint in a diagnostic injection, and they get temporarily better, then you think you found the cause of it, but you may not have. In other words, you may have knocked out all the synovial anti-inflammatory or all the synovial inflammatory cytokines and so forth. So I think it's a great question, and there are those patients in whom we do OCL surgeries who come back in with pain. So I think it's, as surgeons, we have to look around, when we're in there, you have to get rid of all that anteromedial impingement that we've seen. We have to get rid of the anterolateral impingement, and we have to address the mechanical imbalance, which probably caused this in the first place. But I don't have a great answer for, what's the true size of the lesion that determines whether they have pain or not. I don't know.
Well, to comment on that, cysts are there and edema is there on MRI. So it gives you a sign of a lesion, something happened or an evolution of it. But when you have it, the tendency is to address the whole picture, not only the joint, the alignment and the instability. Because if there are variables in our minds, it's alignment and instability that can affect the further evolution of such edema on MRI or cystic changes. But we are afraid of cystic changes because they are a sign of further hydrostatic pressure coming from a fissure in the cartilage towards the subchondral bone, or of an evolution of further degenerative changes.
I would like only to add to your comment about Bronston operation that in French part of Europe we have similar operation that we call it Decanois, and that's basically not reconstruction, but that is a retention of the capsula, and that's exactly in the same philosophy of Bronston operation. Most of people are satisfied, but basically this subtalar problem, we had it when we was more enthusiastic of ligament reconstruction with utilizing Christian Snock operation, and that have give us lots of problems with the subtalar articulation. And I would like also to do some comments about PRP. Basically, when I was in academy a few years ago, and I talk about this biomed system that we have it here for PRP, that was introduced when that was somebody from Stanford, I forgot his name, we discussed, and basically that was for tennis elbow and chronic pathology of insertion that he starts to do it, and now that's spread it to the cartilage because the results of treatment of the tendon insertions are a little bit the same. And it's very difficult for me to understand how you are controlling that this injection goes where you want to go, that's not spreading all around the articulation. I do understand that articulation is much bigger as system, and sometimes anti-inflammatory component is good for synovia, but there is no effect for the cartilage and so on, and how much of growth factor exactly we need for particular operation. That's still we are, maybe that's encouraging, but still there is no so much evidence. Some people are more enthusiastic. Could you do us a little bit more comment about it?
In other words, a lot of new studies are needed.
Yeah, I think you're right. I mean, I think that we don't know the exact quantity. We know that it's TGF-beta mediated, but we truly don't know the quantity of TGF-beta. And there may be negative feedback loops. They may be putting in too much. And so that requires more animal studies and bigger human level 1 studies. But you're absolutely right. It was one of these things that came in, when you have a hammer, everything looks like a nail. And so we just use PRP like mad things. We're using it for everything. And I worked with Mel Glimcher back in the 1990s in Boston when we were looking at bone morphogenic protein. And exactly the same thing happened there. Everybody, as soon as we got BMP, all the spine surgeons were throwing it into every spine there was. And of course it got a bad name because unless you're using it in the appropriate place, it will fail. And so it means you have to take a step back and look at what is the science, what is truly happening here. And then we did that a little bit backwards. We were using it clinically first, and then now we've really taken a step back to see how is it working at a more at a scientific level. And we now know that the science is there, and we now just need to do better trials, and hopefully that's something that we can collaborate on.
I can add one thing about the Broström technique. In his publication, he really reconstructed or sutured together, in most cases, only the anterior talofibral ligament and not both ligaments. And it has been shown repeatedly, I think, that if you do reconstruction of both the anterior talofibral and the calcaneofibral ligaments, the results are better. However, Broström had very reasonable results. Now we have Roald Barr, who is professor in sports medicine in Norway, in Oslo, Norway. He's here with us here. He has a comment.
Well, actually, I am at Aspetar. Mm-hmm.
He is here for 6 months as a visiting professor.
Thank you. I'd just like to challenge you to maybe speculate, taking a little bit of a bird's eye view of the let's say the traumatic side of osteochondral lesions in the ankle. Partly, my background is also that I'm a former volleyball player, lived a life in volleyball. have no idea how many times I've sprained both of my ankles. Have no idea how many ankle sprains I've seen in that sport with all my friends who are now also getting old. Yet I don't know anyone of my friends from volleyball who has any ankle problems today. So the ankle seems to be an incredibly resistant joint in terms of developing osteoarthrosis as compared to the knee, where all my friends who played handball have had knee problems, have substantial problems with knee OA. In my life in sports medicine, since I started, the mantra has been early functional treatment of all ankle sprains, regardless really of the grade of the sprain. And I've seen quoted here numbers somewhere between 10 and 50% of patients have problems 1 year out. And while I agree that might be the case, if you ask patients 1 year out, do you have any problems with your ankle? Most of these problems are, in my experience, very, very limited. So there are very few, really, I think much less than 10% of patients who really have substantial problems with their ankle 1 year out, 2 years out after a sprain. So the question, this was a long comment. The question is, how do we identify? No, one more comment before I answer the question. So we have this new tool now. We can do MRIs of all these ankles, and we're seeing stuff that we didn't see 25 years ago. Maybe we don't even want to know all the things that are going on in the ankle of all these patients that we just sort of treat functionally and let them go back into sport. But the problem is that I have with this is, one, will we someday be able to identify those individuals who will go on to have later problems? 1 year out, 2 years out, 3 years out, 5 years out, and so on. And what do you think we need to do to be able to do this? What is the information that we don't have today in terms of, let's say, the natural history of the ankle sprain and the relationship of later problems to the osteochondral lesions that we've been discussing today? Was that an understandable question in any way?
Should we start with Peter, and John, you can take up?
I will slip the comment and just go for the answer. No, we don't know if instability up to date gives degenerative changes in the ankle. There are people who say yes, there are people no. What we do know is that instability, that malalignment, malunion of post-traumatic fractures or impact of the fracture or the pilon fracture on the cartilage, and the changes in the enzymes or the cells in the joint, they are the triggers for degenerative changes in the ankle. Instability, we just don't know. So,
John,
that's the comment
you
that I
want
can
to add to this?
Yeah, it's a big question and it deserves a bigger answer. Maybe over coffee we can go over it in great detail. But just to sort of bring it back to basic principles, of the 27,000 ankle fractures that occur daily that we hear all the time in the United States, you're absolutely right. 75 to 85% of those will be asymptomatic, get back to their normal functional sports with this triple phase rehab that I think has been originated in Scandinavia, where proprioception and balance that Mike Freeman back in the 60s really sort of identified. This was what we need to do to make sure that we have functional stability. The presence of functional stability and mechanical stability, the likelihood is that patients will do well. But of those 20 to 25% that don't do well, and we all know them because of the patients, you know, we're all told as young fellas, you know, if you sprain your ankle, put a bag of ice out and stick it up on the mantelpiece and you'll do well. Well, most of us did, but some of us didn't. And the ones that didn't, we never really investigated it as surgeons. They just developed arthritis, and we just said, they have a bad ankle, like a bad knee or whatever. So I think there's a much bigger population out there than we truly recognize. And that brings into a really terrific question, because what you're alluding to here is there is screening.
So if you want to screen for this, you have 27,000 a day, you go bankrupt. The healthcare industry would just go bankrupt overnight because you can't MRI everybody. And so if you want to look at the tenets of what you should screen for, it should be a very prevalent injury, which it is. You should have a method for identifying what the problem is, which you do in terms of MRI. And you should have an early intervention that may prevent this from progressing to something worse, which we think we do. But just the magnitude of the problem is so huge, I don't have a good answer of whom should we be screening. Maybe it's that 25% that come to our office. We should be screening those, but that's a huge healthcare problem because that, again, is massively expensive. And so I don't have anything, I can't remember the rest of your question, but it's, has that answered it in any way, or?
Yeah, can I just make a follow-up? It just comes to my mind that perhaps we have spent, in a way, our time looking at those patients who don't do well. So I think we have a reasonable understanding of what their characteristics are when they present with the end result of their problem. But I think perhaps we have to be cautious because we haven't really looked that much at the ones who do well. And the big mistake would occur if they have the same problem, if you understand what I mean. So let's say we take all my ex-volleyball friends and start looking at who have no problems, have sprained their ankle 10 times, who are lax, who but their ankles aren't painful. And let's say we find the same defects in all of those players as well, or former players as well. I think this is the part of the science that we're missing in the ankle, is long-term prospective studies looking at. I mean, when Nick van Dijk wrote his thesis and scoped everyone and found a bucket load of defects in all these ankles, I guess a lot of us were concerned. All right, so you see my point?
It's a very good point. And again, if it's there, it's that old question. So what? Do you need to do something about it? Do we just have an operation that we want to use on something that we see? And that's a very good point, and we don't have all the answers to it. I will say that one of the things that happens to athletes over time is that repetitive injury has a psychological effect on them. And so you get to your 30s and you've had 20 ankle sprains. Well, you're not likely to play at the same intensity as you did before. And your professional era is coming to an end. So I think a lot of these patients who have significant ankle instability and ankle problems just taper their activities based on their symptoms, and they don't come in to complain of it, but it may be there. And it may be a harbinger of arthrosis. Beat Hinterman did that paper where he not looked at just osteochondral injuries, but cartilage injuries. And after fractures and so forth, over 80% of these developed arthritis over time. So we know, even going way back to the 1950s, that any intra-articular incongruity will increase the load. So I think we have to assume that it's there, but it may not be clinically significant because we're not putting the stresses through that we used to. But the problem with the ankle is, unlike the knee and the hip where we develop arthritis, we don't have a good answer for ankle arthritis. So if we can prevent it, it's far better. In the United States, we're using ankle replacements very judiciously. We don't use them as much as I know they do in France and the rest of the world because the results haven't been good in our hands. No, certainly nothing like the hip and the knee.
Okay, I think that we are coming quite close to the end of this session. We have 2 questions left, I think. There are 2 gentlemen here. One of them has a microphone and one of them has raised his hand. So we start with the microphone and then you give the gentleman behind you the microphone.
Thank you, gentlemen, for this valuable lectures. My question is for Mr. Golano. It's about talocalcaneal ligament. This ligament, we are talking about 2. There is one that attaches along the sinus tarsi, and there is one that is outside in the midfoot and perpendicular almost to the ATFL. Are those both continuity or 2 distinct ligaments? There is this talocalcaneal ligament that attaches along the sinus tarsi. That is one. And the second one, we talk about talocalcaneal ligament that is in the midfoot. This one 2 years ago, and the level 1 sports physiotherapy courses, we have been told this ligament, that we have to take care that there's a ligament there and could be also sprained in the midfoot, and his placement is almost perpendicular to the distal attachment of the ATFL.
Maybe it's a cervical ligament?
We call it according to this Queensland curriculum, it's talocalcaneal ligament also.
Yeah. We have different talocalcaneal ligaments. We have one is the lateral, is close to the calcaneal fibula. We have one is posterior, is from the posterolateral tubercle to calcaneus. This is not clear, but maybe is some part of the flexor hallucis longus retinaculum. You have one medial from the medial posterolateral medial process of the talus to the sustentaculum tali. This is very short, also it's not very well described. Also, you have the most important ligament is inside of the sinus tarsi. This is the talocalcaneal interosseous. And you have also another, it is the cervical ligament, but also is a talocalcaneal.
So we have, okay, that's, I got the answer, thank you very much. But, and this, in the sinus tarsi, this one could be provoked by just specifically tracting the talus, the calcaneus, could be provoked, could it stretch it in that way?
Maybe, but I don't remember exist some publication in relation to one author describe a special lesion of this ligament in
Is it important subtalar sprain could be torn, this ligament? Is it important
I'll just sort of answer a little bit of the clinical aspect of that, if you don't mind. I think a lot of the sinus tarsi, which is this sort of non-specific problems patients have in the midfoot, lateral midfoot, is probably from that interosseous ligament, which has been torn and fills in with fibrous tissue. And I think that's very amenable to an arthroscopic debridement. They seem to do well.
Last question of this session. Thanks.
Just a very quick question. I mean, do you have any sort of psychosocial pain generator criteria selection before you do these procedures for patient, or just seeing the pain and the cyst and the edema?
You're talking about the cartilage procedures?
For the osea. Do they go through any rigorous sort of assessment before you do the procedure in terms of psychosocial generator of pain, or no need in such a sport
ordinary
athlete?
orthopedic assessment?
I won't comment on that.
Any comment, Peter, Jack?
No, I don't do that.
Peter?
Well, I think we, as a doctor, are kind of the trustee of the patient. And I truly believe that that connection makes already a big difference. But for surgery, we aim for functional scores. And we don't, of course, we use the nurses use the VAS scores for pain. And in the end, we also, in our comments at the end of the treatment, we describe what patients still feel or encounter, but it's not based on a specific scaling algorithm. So he told me, what I do, we give patients the faith. And I think we all do that. We give them the faith, because even though you do 10 identical lesions, the outcomes are different. But what we want is to people to believe in the fact that it's their best treatment to be better. And perhaps that's a psychological factor, but it's something that plays within every outcome score for surgery as well.
I would say that's something that we have learned very much, for instance, in the era of double bundle and anatomic ACL reconstruction, is to individualize the treatment and learn that every patient is unique, every trauma is unique, every knee, every foot, every ankle is unique, and they are not. We should not treat patients as a group. We should treat them as individuals. I would hereby like to end this session and thank the speakers very much. So with these words, I would like to ask Philip Landraut to take the podium.